Today's topic is PPH. So, introduction. Third stage of labor is most important to mother. So, it is one of the fatal complications which may appear. Important complications are third stage are PPH, retention of placenta, adherent placenta, uterine inversion, and amniotic fluid embolism. In that, most important is PPH. So, PPH could be hemorrhagic or non-hemorrhagic, leading to one of the important cause of maternal mortality. So blood loss of more than 500 ml following vaginal delivery and 1000 ml following cesarean section. Any amount of bleeding from or into the genital tract following birth of the baby up to the end of the puerperium, which adversely affects the general condition of the patient, which is evidenced by tachycardia, that is rise in pulse rate, and fall in blood pressure, that is hypotension. So the blood loss, according to the blood loss, there is a classification. That is, if the blood loss is around 10 to 15%, it is normal with normal blood pressures and only palpitations, tachycardia and dizziness. The degree of shock is just compensated. It means the patient will start having mild symptoms. But if the blood loss is more than about 1000 to 1500 ml, that is around 15 to 25%, the slight fall of systolic blood pressure occurs, that is 80 to 100 is the recorded, and there will be weakness, tachycardia and sweating with mild degree of shock. In case of 25 to 35% of blood loss with 1500 to 2000 ml blood loss, moderate fall in blood pressure, 70 to 80 mm of mercury, and restlessness, pallor and oliguria, with degree of shock being moderate. With blood volume of more than 2000 to 3000 ml loss, that is 35 to 50% of blood loss, there is marked fall in blood pressure of around 50 to 70 mm of mercury. The patient will be collapsing with air hunger, with anuria, with severe degree of shock. So, clinical findings in obstetric hemorrhage is very important, both symptomatically and also the signs and symptoms examination and also degree of shock. So, the amount of blood loss, vaginal delivery 500 ml, cesarean section 1000 ml, cesarean hysterectomy 2000 ml. Types of PPH are primary and secondary. One is third stage and true PPH. So, if the classification is based upon the amount of blood loss, whether it is minor and major and severe. Minor less than 1 liter, major more than 1 liter, severe more than 2 liters. So, primary or secondary. Primary is occurring within 24 hours, secondary beyond 24 hours. Primary is mainly due to bleeding occurring before or expulsion of the placenta, that is third stage hemorrhage, and true PPH occurring subsequent to expulsion of the placenta. So, what are the causes of this true PPH? The definition: causes, risk factors, diagnosis, prognosis, prevention and management. So, third stage hemorrhage is very important. There it is caused by the uterine atonicity and the tissue causes, that is retained placenta and invasive placenta, and trauma causes, that is any injury to the genital tract with inverted uterus, and thrombin where there is coagulopathy, and DIC means defective in the coagulation factors, defective thrombin. So 4 T's, that is the causes of true PPH: tone, tissue, trauma and thrombin. So after the separation of the placenta, the bleeding will continue at placental site as the uterine sinuses that have been torn cannot be compressed effectively. So failure of the uterus to contract and retract is called as uterine atonicity. So the contraction of the uterine muscles compressing the vessels and preventing the blood loss usually occurs with retraction of the uterus. So if the retraction does not occur, all the open uterine sinuses will continue bleeding and it will lead to PPH. So excessive bright red bleeding will be seen. boggy uterus, that is boggy uterus, where the uterus is not getting retracted, it will be soft. High fundus with non-contracting uterus, and abnormal clots, and unusual pelvic discomfort or backache. So these are the findings if the uterus is not retracted. So atonic PPH is caused usually in patients like multiparity, previous history of PPH, fibroids complicating pregnancy, and anemia. So in India, 80 to 90% women are anemic, so they can land up with PPH. And pregnancy complications like APH, like placenta previa and abruption placenta, over distension of the uterus as in twin pregnancy, hydramnios or macrosomia, and labor is prolonged labor, induction of labor, and precipitate labor. And effect of drugs, anesthetic drugs, magnesium sulfate and ephedrine. Whenever the patient is on these drugs, they might develop PPH immediately after the delivery. So we should see that the treatment of PPH or management of third stage of labor is done immediately. So main risk factors are nothing but grand multipara, over-distended uterus, malnourished and anemic patients, antepartum hemorrhage, prolonged labor, anesthesia usage, and also initiation or augmentation of delivery by oxytocin and uterine fibers. In all this causes the tone, that is the retraction of the uterus will be affected, and so the patient will land up with PPH. So placenta. What are the placental abnormalities which will cause again PPH? Mainly precipitate labor and also mismanaged third stage of labor. Precipitate labor is the delivery of the fetus and the placenta occurs within half an hour. So the immediate second stage and third stage will be combined. So this will cause delayed retraction of the uterus because the too rapid delivery of the baby or premature attempt to separate placenta before it is separated, and pulling the cord, and kneading and filling of the uterus, and manual separation of the placenta. All this will cause atonic uterus. Next is traumatic causes. So mainly any traumatic delivery, 20% is the causative factor, usually following any operative delivery, or underestimated blood loss from episiotomy, wound and lacerations, and blood loss in cesarean section around 800 to 1000 ml. And in rare cases, uterine rupture occur if delivery has happened before the cervix is fully dilated. So any traumatic cause should be identified. Any tears in the vagina or in the cervix, and bleeding from the episiotomy wound, and any uterine rupture. All this should be ruled out to and see the traumatic delivery causes. So sites of trauma: vulva, vagina, cervix, perineum, paraurethral region, and also rupture uterus. Here the bleeding is usually revealed but rarely concealed, and in case of vulvovaginal and broad ligament hematomas. So next is retained tissues, that is bits of placenta and also blood clots. This also will cause PPH. Next is coagulation disorders. It could be either congenital or acquired. Sometimes detected usually after delivery, and mainly you will say due to diminished procoagulants or increased fibrinolytic activity. That means coagulation defect. So conditions leading to thrombosis. Sometimes coagulation defect usually occurs following placental abruption or severe jaundice in pregnancy, prolonged retention of the dead fetus, and thrombocytopenic purpura, HELP syndrome, and any congenital coagulation disorders. So we have to see that any patient who is going into labor having these risk factors should be treated cautiously and see that the blood is reserved following the delivery. If there is any immediate PPH, we can transfuse the blood. So what is the diagnosis? How we are going to see all the 4 factors which are causing the vaginal bleeding, whether it is visible as a slow trickle or it is a concealed, or patient is having increased blood loss. So pre-delivery hemoglobin is important. So effect of blood loss mainly depends upon the pre-delivery hemoglobin and the degree of pregnancy-induced hypervolemia, speed at which the blood loss occurs. And there will be alteration of the vitals, usually tachycardia and presence of sweating, dizziness. Patient will be having less BP recordings, systolic pressure will be dropping. She will go into dyspnea. So we have seen the classification. So alteration of the vitals appear only after the class 2 hemorrhage, more than 1000 to 1500 ml of blood loss. So status of uterus should be felt per abdomen, whether it is well contracted and whether it is flabby and becomes hard on massaging. So if it is becoming hard on massaging, that means the cause is atonic uterus. And in traumatic uterus, the uterus will be well contracted, but there will be bleeding from the cervix, vagina, and also any trauma to the external genital. So both atonic and traumatic cause may coexist sometimes. So traumatic hemorrhage causes a state of low general tension, hence making the uterus atonic. So both the causes should be kept in mind when we are treating the patient of PPH. Differences are uterus is flabby and large in case of atonic PPH, and blood is dark in color and no lacerations or injuries can be found. But in traumatic PPH, uterus is contracted and appropriate for postpartum uterus, fresh bright red color. In speculum examination will reveal lacerations, tear or other injury to the genital tract. So difference between atonic and traumatic PPH should be kept in mind when we are examining the patient and start treating immediately. So what is the prognosis? Life-threatening emergencies. Major cause of maternal death in developed and developing countries is the PPH. So there is increased morbidity and sometimes even mortality. So shock, transfusion reactions due to immediate blood transfusion after PPH, puerperal sepsis because of the anemic status and also the wound, sometimes all the lacerations which are sutured or episiotomy wound, all this can get infected because excessive meddling of the patient and also the tissues. Patient has to be kept under strict observation. And failing lactation might occur due to PPH and pulmonary embolism, mainly because of the blood transfusions and also any complications related to amniotic fluid or thromboembolic disorders in the periphery. Late sequel is Sheehan syndrome. Sheehan syndrome is nothing but postpartum pituitary necrosis, where the patient will end up with the features of syndrome with amenorrhea, poor general condition with no lactation. And Sheehan syndrome, postpartum pituitary necrosis due to severe hemorrhage or shock. As the blood loss occurs during labor, there will be hypopituitarism, which will affect the antiopituitary hormone deficiency, and it will be evolved slowly and diagnosed late. So how to prevent? Mainly, the risk factors should be kept in mind, but sometimes we cannot prevent it. So incidence and magnitude can be reduced by assessing the risk factors and following the guidelines. So most cases have no identified risk factors. We cannot assess PPH. So improvement of the health status. Keep the hemoglobin level normal. That is more than 10 gram per deciliter. High risk patient need to be screened and delivered in a well-equipped hospital where there is blood grouping is done and blood bank is available for the immediate blood transfusion. So placental localization must be done beforehand with the ultrasound because APH is one of the causes for PPH. So whenever there is morbid adherent placenta, we have to see that it is done systematically and according to the protocol. Because if the adherent placenta is not dealt with in higher center, we can see that the maternal death might occur. So intranatally, active management of third stage labor, where immediately after the delivery, you have to give oxytocin at least 5 units, slow IV immediately after the delivery of the baby, and to prevent the traumatic PPH, exploration of the uterovaginal canal for evidence of any trauma should be done. So what is active management of third stage of labor? It is nothing but administration of oxytocin 10 minutes IM after delivery of the baby, cord clamping after the cessation of the cord, and uterine massage should be done. It has been estimated that the routine use of this active management of the third stage of labor reduces the chance of PPH by nearly 60%. Hence, it should be delivered, and particularly in countries like India, where the PPH still remains a cause of death, usually in underdeveloped countries.